Welcome to lecture number 1 for medical students and off-service residents. The purpose of these lectures is to give you guys a base foundation for us to teach on during your time with us. Anesthesia can be pretty fast-paced, especially in the mornings, so I'm designing these little primers to be watched or read at your own leisure, the night before or on the car ride in. Sometimes we have 70 to 90 cases to get done in a day, and we're zipping around and we might miss out on key learning opportunities. So by no means is this a comprehensive review to the level that an anesthesia resident should be learning, but it should be able to give you guys a good base foundation of what we're actually looking for in an anesthesia assessment. So I hope this helps. Without further ado, pre-op assessment, let's talk about it. These are my learning objectives because apparently you always have to have those written out. You can't just talk about it. But basically, this is what you're going to hear me yap about today. Let's get into it. Okay, so first things first, let's talk about when the pre-op assessment takes place. Obviously, before the operation, hence the name. But there are different scenarios in which the pre-op assessment begins. For instance, most outpatients are seen by their PCPs or a dedicated pre-op clinic either months to weeks before the procedure. They are still then seen and assessed by the anesthesiologist the day of when we do our own assessment. Inpatients are typically urgent or emergent surgeries, so here the evaluation will begin with the hospitalist and then us leading up to the surgery. So why do all these people need to assess the patient's readiness for surgery, especially since I, the anesthesiologist, am going to see them anyway? Why not just show up and figure it out then? Our answer is patient safety. It's way better to identify intraop risks so that you can treat them weeks or days in advance. For instance, finding out a patient is hypokalemic an hour before the surgery will definitely lead to a case cancellation if it's elective. But if seen by their PCP or the pre-op clinic, they could already be on supplements and be good to go. The hospital's answer to this is money. When cases get canceled, sterile instruments get wasted, time that staff are getting paid gets wasted, and then they end up having to pay overtime to get the other cases done for the day. On average, it costs about $17,000 to run an OR from 7 a.m. to 3 p.m. That's paying for equipment, nursing wages, and etc. And to recoup that money, cases need to be going to bill for and cover those costs. Lastly, we got to think about the patient. They call off work, they arrange rides and babysitters. Sending them home comes at a cost for them too, so we want to optimize everything for everybody. So what are the main components of the pre-op assessment? There's history taking, that's including chart review, physical exam, including airway assessment, risk stratification and ASA classifications, further testing and imaging if necessary, and then we make the decision whether to optimize the patient further and delay, or proceeding with the surgery. We will break these down individually. So what's important in an anesthesia medical history? We don't need to go back to APGAR scores on our adult patients. Maybe that'd be relevant for a preemie with necrotizing enterocolitis, but you get the gist. We take a focus history. So big things we care about are previous anesthetics. We want to know, based on the chart review, were they a difficult intubation last time? Maybe they took 2 attempts with direct laryngoscopy. That's relevant to us. Maybe it was extremely difficult and they just barely made it. And sometimes patients even come in with a printed document from their last anesthesiologist with exactly what happened and recommendations for future attempts. We think about hereditary things like malignant hyperthermia or pseudocholinesterase deficiency. I'd say about once a month I run into people with a family history of one of these, and we need to know exactly what to do to prevent a reaction. Also in the history, we're going to do a comprehensive review with the patient to make sure we didn't miss anything in the chart. I always assess the stress a patient can take, also called their functional status, which we'll discuss. We do a medication review to make sure that they continued the correct medications for their ailments and discontinued the correct ones. And then we talk about what allergies they have, determine the severity, because everyone's allergic to penicillin, but nobody actually is. So we inquire about what type of reaction it is, a rash, whatever. Benadryl makes you sleepy, whatever. Contrast closed your throat and you coded last time? Yikes. All right, we'll avoid that. Lastly, we make sure that they're NPO appropriate, and I'll explain that in a later slide. So now let's talk about the comprehensive review. There are many ways to get the information you need from a patient, but the two main methods that I see the most are systems-based and head-to-toe method. Systems, you just have to remember to hit every major organ system. So neuro, ask about seizures and strokes. Any positive answer gets follow-up. So if they have MS, you dive into when was your last relapse? What medications do you take? Are you on steroids right now? Cardiac, you'd inquire about heart rhythms, stents, chest pain, their functional status, and so on. In the head-to-toe approach, the one I use, so obviously it's the best, I start at the brain, asking about seizures and strokes, then the mouth, about smoking, NPO status, allergies, do my airway assessment. Next, I go to the neck, so asking about thyroid issues and diabetes. And then chest, being the heart and the lungs, and so on. Just pick a method that works for you. My simple mind needs to focus my eyes upon a body part and then ask the questions and make the connection there. You keep hearing me say the phrase functional status, but what does that mean? It's the assessment of a person's ability to perform daily tasks. This helps us to stratify perioperative risk, particularly cardiovascular risk. One metabolic equivalent, or MET, is the resting O2 consumption of a 40-year-old 70-kilogram male. So that's just chilling on the couch. Different activities have varying METs associated with them. And as you can see from the figure, taking care of yourself doesn't require much effort at all. Getting dressed is 2 to 3 METs. But some patients are that limited in their capacity and are therefore at higher risk. Not being able to complete 4 METs is where we see elevated cardiac risk. I typically start by asking, can you walk up a flight of steps without stopping or getting chest pain? If yes, I proceed because that's about 4.5 METs itself. If they have more risk factors, I may inquire more. In short, if you can't walk 2 blocks without stopping, you're at elevated risk because you're less than 4 METs. If you have chest pain or get short breath just watching TV, you're cooked. But now there's a subset of patients who, for different limiting factors, maybe they have really bad back pain or need a knee replacement, they're not going to be able to walk up a flight of steps or 200 yards on flat ground. You take an individualized approach for those patients as well. Some of them, you would just do cardiac testing just because we can't assess them. Some of the risk stratifiers you'll come across are the RCRI and the Gupta perioperative risk calculator. I could talk all day about these, but both are useful tools that we utilize in conjunction with the patient history and physical. Both of these calculators can be found on MD Calc, and I recommend you guys adding them to your favorites. Whether you're in internal medicine, anesthesia, or surgery, you're going to be using this. You answer yes or no and type in patient characteristics into these calculators, and that determines their 30-day risk of MACE. And MACE is major adverse cardiac event. On the RCRI, it's easy. If you say yes to any one of these questions, do you have heart disease, history of CHF, stroke, etc., your risk is automatically over 1% and needs to be looked into further. So we gathered a bunch of information. Now what do we do with all that? The American Heart Association suggests that we use this algorithm below for patients with cardiac risk factors. This image is confusing, so I'll break it down for you. So we have our patient, we did the history and physical, and then we got down to these calculators. If the risk is less than 1%, we can go ahead and do the procedure if everything else is good. Greater than 1% risk means that we need to assess their functional status. And remember, greater than 4 METs means that a patient is at higher risk. So, say we use the RCRI. We got a greater than 1% risk, meaning that they said yes to stroke, CHF, or ischemic heart disease, and they have low metabolic function. Low METs. That means that we need a stress test, which, if positive, might require a possible cath and coronary stents. If it's an urgent surgery, we're just going to end up skipping the stress test and do the procedure knowing that they're at high risk of MACE. Why would we do that? Because if you make cardiology put a stent in and you get put on aspirin and Plavix to stop that stent from thrombosing, I don't want to get too into the weeds, but stopping someone's DAPT therapy within 3 months of a stent could most definitely cook them. so instant thrombosis risk. So biggest take home for today, don't cook your patients. So let's talk about medications. At some point, the patients are going to receive a list or a phone call telling them what medications to take and what not to take before surgery. There are some obvious ones like blood thinners, because why would we want them to bleed more? But things can get complex depending on what type of anticoagulation they're on and why. For instance, warfarin users typically hold this medication for 5 days before surgery. But certain patients are at elevated risk of clotting while warfarin's wearing off, particularly people who have had a recent stroke or patients with mechanical mitral valves. These patients, you would need to bridge them with Lovenox or heparin. We do this because Lovenox and heparin are shorter acting, so have shorter half-lives. So if we bring the patient in 3 days before the procedure and start them on a heparin infusion, we can keep that infusion running up until 6 hours before the surgery, press pause on it, let them have the surgery, and restart it as soon as their bleeding risk has gone away. ACEs and ARBs, if you take those, you're at increased risk of intraoperative hypotension that can be refractory to some of our medications. Some anesthesia docs are completely against doing any elective case if they took their lisinopril, and some are cool with it. Recent literature suggests that though there is increased hypotension risk, morbidity and mortality don't seem to increase if people continue their lisinopril. There's a specific subgroup of people that you might want to consider continuing their lisinopril on. So if you remember heart failure with reduced ejection fraction, these people, you would want to decrease their afterload to promote their forward flow because that would increase their ejection fraction. Next, we'll talk about SGLT2s. You can get a euglycemic ketoacidosis, so we typically have people hold those before surgery. I've only seen this once in residency, and it was kind of cool to figure out what was going on, why our patient was acidotic for no reason. GLP-1s, like Ozempic, can delay gastric emptying, and a bunch of people were having large volume aspiration events under anesthesia when this was new. Now there's a new debate on whether to hold this medication currently. On the continue side, I'll just mention beta blockers. We want to continue those due to the mortality benefit in heart failure and coronary artery disease. However, there was a study called the POISE trial where patients with cardiovascular risk factors were started on metoprolol the day of surgery and continued for 30 days. These patients had an overall decreased risk of MACE, so cardiac events, at 30 days, but unfortunately, they had an overall increase in all-cause mortality and stroke. So based on this study and another trial called the DECREASE trial, it's been shown that starting and tapering beta blocker therapy 3 to 4 weeks before surgery doesn't increase all-cause mortality and provides decreased risk of cardiac events. So in short, starting beta blockers the day of surgery for patients with cardiovascular risk factors, don't do it. If they are already on beta blockers, keep them taking their beta blockers. Trust me, that was important. The next thing we do is determine if our patients are NPO appropriate. NPO stands for nil per os, which means don't let them eat in Latin. Or it means nothing by mouth, but no one actually understands Latin, so you'll never know the difference. But we do this to avoid aspiration of gastric contents. When we give medications to induce anesthesia, we take away your airway reflexes. When you're awake, if something goes down and tickles your vocal cords or your trachea, you're going to cough involuntarily to avoid aspirating. Under anesthesia, though, that cough reflex is blunted or completely absent. So to decrease the risk, we typically have elective cases come in with an empty stomach. So how do we tell if someone's stomach is actually empty and someone didn't cheat? We could gastric ultrasound them and identify the contents and volume, but that would take forever for every patient. And for instance, at my hospital, we only have 3 ultrasounds and we might have 20 patients for first start. But what we do know is average gastric emptying times for different foods and liquids. Table 2 here, you can see that clear liquids should be out of your stomach in 2 hours, breast milk and formula 4 to 6, solids, depending on the type, 6 to 8 hours. To give you some real world examples, Gatorade or, say, soda, it's a clear liquid, and you would have to wait 2 hours before surgery. A light meal like toast, 6 hours. McDonald's is definitely going to be an 8-hour wait. So why do you think we tell patients in the hospital or coming in for elective cases not to eat or drink anything past midnight the day before? And you probably guessed it, it's because they're going to mess that crap up and jack up the timing and potentially get their case canceled. But the good thing is, if they did mess up, we use these guidelines to say whether they have to wait for their surgery, come back another day, or if we can proceed. For instance, if a dude comes to the OR and says, "Oh, I got thirsty, woke up in the middle of the night and drank some breast milk at 4 a.m., and it's 8 a.m. now," we could then ignore the fact that a grown man is drinking breast milk and proceed with the case. Sorry, that was a weird example. But this aggressiveness with telling people midnight becomes problematic for, say, diabetics, where prolonged fasting could lead to hypoglycemia because they're still taking their insulin. It also sucks because almost all patients are told to stop at midnight. So when the operating room runs slow or people had later cases, they are then starving for needless hours. And fortunately, this is something that everyone's aware of. So typically for kids, we try to have their cases done as early as possible so babies aren't crying and parents aren't miserable. Type 1 diabetics typically get a first start case, so they can get back to eating as soon as possible, as soon as their case is done, so they can maintain their homeostasis with glucose therapy, glucose and insulin treatment. VIPs also might get a first start case because you best believe that I'm not fasting until 3 p.m. No, sir. In short, NPO after midnight as a practice sucks, but we're working on it and discussing it. But for now, it kind of is what it is. Here we have some ultrasound images of a stomach. To review some of the anatomy, right here we see the liver. What we're looking at here is the antrum of the stomach. So when your stomach is filled with fluids, it'll appear black within the antrum of the stomach. In this image to the left, this is the outline of a distended stomach digesting fluids and solids. On the right, an empty stomach, we're going to see an antrum that is hyperechoic, which means it is bright appearing, and that is the muscles of the antrum collapsed on each other because there's nothing in there to be digested. Just a helpful 2 cents for you guys when you're taking care of surgical patients. If a patient is NPO before surgery and they don't have some crazy stomach pathology or whatever, if a patient asks for ice chips, it's literally fine. You don't have to be that much of a stickler because we know that gastric emptying time for water is about 20 minutes. So you can always give ice chips, sips and chips, or whatever. If anyone gives you crap, you got it from Dr. Gray, but I'll deny it. So moving on. So that completes the history. I know we've been talking a lot, but just recapping all those questions that we're asking the patient, the chart review, all that's part of the history. If they're NPO, what their functional status is. Now we can move on to the physical exam. So every patient is going to come in and get a set of vitals so we know what their baseline is and we can become aware of any abnormalities. We then perform an airway assessment to determine if there will be a challenge to intubate or to manually ventilate. We do a standard heart and lung and focused exam based off the history that we took. So if they had a history of heart failure, I might squeeze their calves to see if they're fluid up. I'll do the same thing if someone's got CKD and see if they need diuretics or if they need dialysis. I also employ something called the eyeball test, where as you guys continue to practice medicine, you'll have a keen understanding of what a sick patient looks like or what someone who is frail looks like. And we keep that in the back of our mind, so when it comes to medication dosing, we can kind of hit a sweet spot and not overdo it or underdo it for somebody. Airway assessment is a rather large topic that cannot be covered in depth here today. We'll probably circle back to it at another point. But what I want you guys to know is these big take-homes. What you're going to be seeing me do a lot in the pre-op evaluation is having patients open their mouths and stick their tongues out. Being able to see the entire uvula above the base of the tongue is a good predictor of ease of intubation, as you can see in these images right here. This is called the Malampati classification. I assume that some guy was named Malampati who made these. But in this first image, you can see that there's a lot of space between the uvula and the base of the tongue. So that's the more space, the better. That's a class 1 airway for us. The second one, there's less space, but you can still see the uvula above the base. These are considered really good predictors of ease of intubation. Once you start getting into these patients where you see less and less in class 4 airway, all you see is just the back of the throat. That would be a poor predictor of intubation ease. And then we might need to, instead of direct laryngoscopy, we would want to use video laryngoscopy. Now there's other predictors, a bunch of other that you can see in this table here, like limited mouth opening. If someone has really long teeth, the less space you have to get a blade and a tube in somebody's mouth, the harder it is to intubate them. Neck range of motion. If you think of people with ankylosing spondylitis, if you're studying for a step 1 or step 2, remember HLA B27 for those patients. Sometimes they're fused completely from like their thoracic vertebrae to their cervical, and some of these patients are perpetually just looking at the ground because they cannot move their neck. That would be a difficult intubation. We're almost done. Stay with me. The next thing I do is I ask myself if I need any further testing, whether it be electrolyte panels, a CBC, or a type and screen. What we do want to do is limit unnecessary tests that won't change our patient management. All that does is increase costs and waste time. So I'm not going to delay an emergency by getting a CBC. And a 20-year-old doesn't need labs for a low-risk procedure if they're otherwise healthy. On a quick side note, I tend to overuse the phrase otherwise healthy way too much. For instance, on internal medicine, I'd give a case presentation. This guy has CHF, brain bleed, and he got shot 5 times, but otherwise he's healthy. So don't do what I do, don't get roasted, and do better presentations than that. But anyways, there are patient-specific factors and procedure-specific factors that warrant testing. For instance, it makes sense for everyone to have a type and screen for a bowel resection because we may need to transfuse you. And the patient with cardiomyopathy should probably have basic labs done even for a colonoscopy, when other patients, otherwise healthy patients, don't. Imaging is rare preoperatively because most cases would get canceled because TTEs are seldom done the same day. You have to be pretty bad pulmonary-wise for me to get a chest x-ray or a CT on you before we go back. If I thought you were that bad, I would say go to the ER and get admitted. But if it was an emergency case, we would just, again, go with the risks of having poor pulmonary outcomes. I myself did get a chest x-ray recently, and it was confirmed that I do, in fact, have that dog in me. As a matter of fact, you can actually see that I have multiple dogs in me, right here, here, and there. But you know the ABCs of reading chest x-rays. I don't want to skip over anything, but you inspect the airway, then the bones, make sure everything's good, the cardiac silhouette, and then D for that dog. Yep. Okay, I'm done, I promise. I'm done being dumb. Okay, we'll snap back to reality. I had to keep it loose and light just because we all know that being hands-on is the best part about being anesthesia. So no one wants to sit and listen to me yap all day. So let's get back into it. At this point, we've done our history, our exams, and our extra testing. We then ask ourselves, is the patient optimized to their fullest extent? Have major risk factors been identified and minimized? For instance, do they have asthma or COPD? Do they have mild wheezing on exam with it? Or a full-blown exacerbation? Because mild, I can give albuterol or a duoneb, albuterol and ipratropium for med students who don't know the brand names yet. Full-blown, you got to delay it if it's an elective case. If it's an emergent case, you just got to deal with what you got. And potentially this patient might be going to the ICU because their lungs are so bad. If they're optimized, you can give them the green light to go ahead. The last part of anesthesia assessment is assigning an ASA classification. This is important because many specialties use this system. ASA stands for the American Society of Anesthesiologists. We assign patients a number based on the type and severity of their comorbidities, typically from 1 to 5. 6 is a brain dead patient for an organ harvest. An ASA 1 is described as a normal, healthy patient, so it's tough to be a 1. BMI has to be under 30, and practically no medical conditions. I find it rare out here to be under 35 years old and be an ASA 1. BMI is typically what gets you. ASA 2 means mild systemic disease, so if you smoke, weed, cigarettes, or vaping, BMI between 30 to 40, and have hypertension or diet-controlled diabetes, we'd call you an ASA 2. A 3 is severe disease, so anybody that has a pacemaker, on dialysis for ESRD, COPD, CAD with stents or bypass in the past, diabetes, and you're on insulin, etc. A 4 is any disease that's a constant threat to life. So this can vary. So if you have severe cardiomyopathy with an EF of 20%, that's you because you could go into VFib and die of sudden cardiac death. Stroke or an MI within the past 3 months would make you a 4 because you're at high risk of it happening. You're at high risk of it happening during the procedure and 30 days post-op. A 5 means that you're going to die without the procedure. So think of a trauma who got shot in the chest, again, otherwise healthy, or a ruptured berry aneurysm or a AAA. These people may be an ASA 1 or 2 20 minutes ago, but now they're 5. So what this system does is it helps us to communicate with other providers how sick and risky a patient is. If a colleague comes and gives me handoff on an ASA 1 patient, I'm going to take my time going to check them out. If they say ASA 3, I raise an eyebrow. A 4, that's a patient that needs a lot of attention. Everyone gets attention, but the sicker, the more involved you get. These examples that the ASA gives us aren't all encompassing, so I use my clinical judgment when assigning. For instance, this chart would say COPD is an ASA 3 criteria. So fair. If you have a COPDer, that's the minimum that you are. If you have COPD and you need oxygen 24/7, the studies show that your 5-year mortality rate is 30 to 50%, which is huge. And not having oxygen is a constant threat to their life. So I would call that a 4, but some call it a 3. But again, it is what it is. Everyone gets the gist. This is the last slide, I promise. So we finally made it. We did our pre-op assessment and we determined the patient it's okay to have surgery. The next thing we do is we give them the thumbs up. We finish off the pre-op phase with our anesthesia consent. We go over the risks and benefits of different types of anesthesia. I confirm that the patient is the correct patient and that we're working on the correct part of the body. That's extremely important. Multiple people will be asking the patient and marking the patient to make sure that we don't do a wrong-sided procedure. Once that's all taken care of, we can start giving pre-medications. A lot of people are nervous before they go back, so we typically give them midazolam or Versed. It makes it easier for us to put them to sleep, and you also don't have a patient that's freaking out when they get into the operating room and they see a bunch of blades and robots and bright lights that would cause anybody anxiety. Lastly, other medications we can give. If you have asthma, I might give you some albuterol. If you have a history of motion sickness or being sick with anesthesia, you can get antiemetics. And that's pretty much it. You go on to the next phase, and that concludes our pre-op assessment lecture. So thanks for bearing with me. I know I have a PhD in yapology, but I'll work on that for the next videos. I lied, there's one more slide. These are all the references that you are responsible for reading and writing a report on. Thank you.